cameras for help with this presentation. So for our introduction, we're going to talk a little bit about the definitions of sepsis and septic shock, and previous trials that have been put in place looking at steroid use in these patients and why it was thought of as possibly beneficial, and then a review of the Adrenal trial with its methods, results, and a discussion at the end. So first of all, sepsis and septic shock. There are a couple of definitions that it's important to know about. So we've got them written there. Sepsis is characterized by a life-threatening organ dysfunction due to a dysregulated host response to infection. And septic shock is a subset of sepsis where particularly profound circulatory, cellular, and metabolic abnormalities increase mortality. And then if you have a look at the bottom, we've just put in place that septic shock is sepsis with a persistent hypertension requiring vasopressors to maintain a MAP or and a lactate greater than 2. Okay, so we'll move on to the next one. So what is happening in sepsis and septic shock? Well, as it said on the previous slide, it is just an overreaction of the normal response, the normal immune response. So normally you would get vasodilation, and then this is followed by capillary leakage so that your mediators can enter the tissues and thereby attack anything that has entered the tissues that shouldn't be there. And then you get amplification of that process. But what happens in sepsis is there is a greater amplification, an over-amplification, and that leads to the clinical picture that we see. So steroids, as many of us are aware, are used to try and ameliorate this by preventing that amplification process, and they have been used for ITU for the critically unwell and those with septic shock historically. And the idea is that they can halt the inflammatory process and they give better hemodynamic stability in these patients. And all of the lab results and tests within laboratories have shown that that should theoretically be the case. The steroids are not used in order to cure sepsis. They're purely used to try and improve the hemodynamic stability of your patient. And they have to be therefore be used against other treatments such as antibiotics, vasopressors, fluids, and other organ support.
So we just briefly wanted to include a couple of trials that have been performed before looking at hydrocortisone therapy for patients with sepsis, and there have been quite a few large studies done. And just on the next slide, we've just summarised a couple of them, but essentially none of the trials so far have shown a statistical significant improvement of outcomes of using steroids with sepsis. And the high press trial, if I'm saying that right, listed actually some adverse events of using hydrocortisone, so hyperglycemia in particular, but also things like secondary infections and weaning failure as well as a result of the trial. So then moving on to what this trial did, the clinical question was looking at whether hydrocortisone results in a lower 90-day mortality than placebo in specifically mechanically ventilated patients with septic shock. The trial was designed over quite a long period of time, so it was a over 4-year trial study, and it looked at 69 different intensive care units across the countries. You can see those written there, and it was a randomized double-blinded control trial. And as part of the methodology, they stratified patients as to whether they were a medical or surgical admission. I won't go through all of these, but there was quite clear inclusion and exclusion criteria. Obviously, they had to meet the criteria for sepsis, so it was 2 of the SIRS criteria in order to be eligible for trial inclusion, and also on vasopressor or inotrope support for greater than 4 hours and ventilated. And then the exclusion criteria included if they were likely to receive steroids for something else, and also if they had received etomidate, which is a short-acting anaesthetic agent that has adrenal suppressant properties, so that would also exclude you from being able to be included in the trial. And also if the patient was likely to die, if they were so sick that the hydrocortisone is unlikely to make any difference, they couldn't be included either. So then the trial intervention, and this is slightly different to some of the previous trials we had up earlier, which used different doses of hydrocortisone. This trial did an IV infusion of hydrocortisone, 200 milligrams over 24 hours, and that was given for a maximum of 7 days unless the patient left the unit or died before then. And actually it was given correctly in pretty much all cases, which was good. And the placebo was very similar, given again correctly in most patients, and there were no problems with that. So how they measured outcomes was split into primary and secondary, and they, again, you can read these, but it was looking at whether the patient died from any cause at 90 days, but then also looking at any death in the initial 28 days after receiving hydrocortisone as well as collecting whether they received a blood transfusion or needed to go on the filter, or any new onset of infection post having hydrocortisone, which in the previous studies they found increased adverse events with increased secondary infections. So this was particularly relevant. So they got almost all the patients they needed. I think they, in order to have 90% power, 3,800 patients were required, and they managed to recruit 3,658, pretty much even with who got hydrocortisone, who got placebo, and a couple of patients were lost to follow up. When looking at the patient's characteristics in depth, they found that there was no real significant differences in demographics and their baseline in between placebo and intervention, but also in between who'd been streamed to medical versus surgical admissions.
So now moving on to the results and looking at the primary outcome, and it was found that there was no statistically significant difference in mortality between the two groups. So at the 90 days, there was no difference between the hydrocortisone group and the placebo group between the number of people who had died. There were some statistically significant results when they looked at the secondary parameters that they were looking at. So if we go through the list there, time to the resolution of shock was shorter in the hydrocortisone group, as was time to discharge from the ICU. There was also a shorter duration of the initial episode of mechanical ventilation, and those patients that received hydrocortisone were also less likely to receive a blood transfusion. So there was some differences between the two groups. However, a lot of the other parameters showed no difference. You can read through the list there, but one of the important ones is that they didn't find any statistically significant difference between new onset bacteremia or fungemia in the hydrocortisone group. So the merits of this trial, we thought it had a well thought out methodology. They gave all the reasonings behind the decisions they had made. So reasons as to why they didn't taper steroids, because there was already research out there that showed this was not beneficial. Unlike some of the other studies that we talked about earlier, these ones were given, the steroids here were given as an IV infusion. So that prevented some of the effects of just having a bolus dose each day. And the statistics were analysed independently from any of the researchers by statisticians, and all corrections were made for the multiple different statistical methods that were used. So they used Bonferroni corrections, for example. There were some limitations to the study, of course. We've already talked about the fact that they didn't quite have enough participants to obtain the power that they wanted. There was also no data on the specific centres to indicate whether there had been any variation between the centres, which could be later explained. They also used rates of recurrence of ventilation as a surrogate for myopathy, but didn't assess in any way long-term neuromuscular weakness when they were looking at the secondary factors. And there's also, as you saw, a very tight inclusion criteria. So the questions that we were asking, would IV hydrocortisone be more beneficial in some of the excluded cohorts? So maybe some of the sicker patients that had been excluded from this study. So in conclusion, there was no statistical significance at 90 days between the placebo group and those receiving hydrocortisone. And so we can't advocate the use of them, but however, there was some benefit in respect to the secondary outcomes, but a full cost benefit analysis would have to be done to assess whether it is still worthwhile using steroids in certain patients. Any questions?
Yeah, thanks. That was really good. Good analysis of it all. Thanks very much. I mean, sadly, it's another one of those ICU trials that everyone was waiting for and went, oh, well, actually, there's not much difference. So my question to you guys is, what do you think the main factor, because you mentioned earlier that they didn't standardize protocols throughout the ICUs and where, you know, different countries and whatever. What do you think the most major factor was that may have caused clouding of the outcomes in this? So do you see what I mean? What clinical practice do you think caused the biggest sway in the data that people didn't standardize? If you could choose.
Well, I suppose it would be the 4 hours from diagnosis of shock, because I mean, some centres may be diagnosing that pretty much as they enter the hospital, whereas others it may be further along in the patient's progression. So you're not really sure where these patients are being, what point these patients are being picked up, and whether you're really comparing like with like.
Yeah, I agree on that one. Has anyone else got any suggestions on something that could have been a confounder in all of this that could have swayed the data? But I agree on that, Eleanor, definitely. Anyone else? What do you notice between units that may be different when you go to a unit, say, down south or one further up north? Anything you notice that's different, apart from the weather?
I was going to say climate.
Yeah.
No.
Anything else? What about antibiotic usage? Any thoughts?
Oh yeah, I suppose Charlotte was just mentioning whether there's different antibiotic resistance, and so different antibiotics are used in the different centres.
Absolutely. I think that's quite a major one, because it may be that, you know, we all know what the yield of blood cultures is. It's not very high, but nonetheless, there might be different growths of different bacteria in different regions and so forth. So, you know, one region might treat Haemophilus differently to another region. So that might have had quite a major effect on it all. And the other side to this is the infusion possibly led to decreased time on the ventilator and decreased time to target maps and things like that, but it's probably quite expensive. So the final question I've got, and I'll shut up, is anyone going to change their practice from now on the result of this trial?
No.
And there you go. But nonetheless, a really good trial, and one of the biggest of its kind, I think, out of all of the ones that was listed on that lovely timeline that you showed before. So yeah, has anyone else got any questions or anything, comments? No? I'll give you 2 more seconds. Anyone else? Liv, anything to say? No?
No, not really. No, I'm not. It won't change my practice. I guess when you come into situation with this of vasoplegic and sepsis, our options are so little as it is. You know, what works, what doesn't work.
Yeah.
I guess it's a last ditch attempt, isn't it?
I think so. put it this way, it's not an activated protein C trial where everyone just got the shock of their lives, basically.
It's cheap as chips. The problem with activated protein C, it costs an arm and a leg.
£96,000 for a 4-day course, I believe. Don't drop the vials. Yeah, brilliant. Well, thanks for that, Liv. Okay, that was really good. Thank you very much. I shall stop the recording.